Good afternoon, everyone. My name is Max Boykin, working for AIDS Foundation of Chicago, and this is our AIDS Foundation of Chicago webinar on Illinois Getting to Zero, which will be presented by Jolie Holliman today. Our webinar instructions are this webinar has too many attendees for questions to be submitted over the phone. All attendees are in listen-only mode. Everyone can submit questions at any time using the question feature. During Q&A, which will be after the presentation that Jolie is doing, I will read selected questions that have been submitted. So please submit those questions on the question feature. There's a question box on the side here. You can submit questions there. Please do, and I will be reading them out aloud in order for Jolie to answer those questions. If you have any email, if you also are on your email, you can email questions at joaks@aidchicago.org. Now, introducing Jolie Holliman to start the Getting to Zero presentation. Go ahead, Jolie.
Thank you, Max. I appreciate it. Good afternoon, everyone. Thanks for joining us. This afternoon's Getting to Zero conversation has a few objectives. So we're going to share a little bit about the Getting to Zero framework, the meaning, those who have participated in creating the framework thus far, talk a little bit about our current state, and then the Getting to Zero aims and our overall timeline. But another part of this, of our time together, is to get your input and feedback. That's really important to us. Next slide, please. So we begin with me kind of asking you to go back. Some of you can go back further than others, but just thinking about your time in this field, how you think about the epidemic. And I know we're limited in how we can have this conversation, but please, again, as Max said, feel free to throw in your comments and questions in the chat, and we'll talk through that way. But kind of think about how you would describe the HIV epidemic in the 80s, you know, when it first came out. And I know we've had these conversations before where a lot of people speak about in the 80s the fear and thoughts about it being a death sentence. And it, like I said, if anybody else has anything else to throw out, you can throw it out as well now. But think about the progression. What changed in the 90s, you know, or in the 2000s? You know, what new medical advances as far as the medication, fear, death. Thanks, Max. Yeah, when you talk about the 80s, for sure. And then the progression of medication, and there being in the 2000s and even now, today, more hope. More hope, but then again, also those people who don't even think about it anymore, don't talk about it anymore, feel that this is something that has been solved. Some who think we've already gotten to zero. Thanks, Max. I also see yours too about those who are living with HIV, living longer, striving, not just living but thriving. So things have definitely changed. When we think about getting to zero, ART and PrEP for sure, antiretrovirals and PrEP medication for prevention. So we've definitely seen progression from the 80s to today. Next slide, please. When we think about getting to zero, and the way that the initial group who's been talking about this and talking about the framework, we think about getting to zero new infections as we talk about it, but also getting to zero detectability, zero people living with HIV who are not in care and in treatment. That's what we think about when we're talking about getting to zero. Next slide. So when we talked about getting to zero and the getting to zero group and framework, just to kind of give more information and background about what it is, the group was comprised of people who are living with HIV. It was other community advocates who were involved and service providers, but also there were government officials. So we've always had IDPH and CDPH at the table thus far. Next slide. In addition to that, it's also a framework. This framework is, and I put the skeleton because I really wanted to make it clear that this is just a skeleton. But it's a framework to dramatically impact the course of HIV in Illinois. It's looking at bare bones. What would need to be done for us to actually get to zero in this state? Next slide. In addition, the Illinois Getting to Zero group and framework is offering opportunities statewide. This isn't just a Chicago thing, but statewide to provide opportunities for people to provide input on the Getting to Zero plan. And it has been inspired by efforts in other areas. New York has a Getting to Zero plan, San Francisco, Washington State, and Arizona. So this conversation, this initiative has really been inspired by other precedents. Next slide. I wanted to share this with you. This is an example of the Arizona HIV Getting to Zero initiative, and they've created similarly a statewide group that is looking at a plan to end HIV in their state. It's something that was shared with the group, and it really did inspire us as we were thinking about what's happening in our state with our budget, with all things considered. Can we still work together and make sure that everyone who's living with HIV is getting the treatment that they deserve, getting access, and that they can get to detectable and they're getting the services that they're needing. But then also, are we making sure in this, can we do something to make sure that the prevention is there, that we're using all the new biomedical and technology in order to make sure that we're getting to zero on the side of zero new infections as well. Okay, thank you. That's the end of that slide. So it's great to see that slide, great to see what other states are doing and feel inspired, but this is kind of where we found ourselves. This is what I think of when I think of us as a group, which was, yeah, these things sound great. We want this change in the state. We want this change in Illinois. Yeah, we all want it. Yes, let's go for it. But then the bottom part of that is, but who wants to change? Because we know that in order to have change, we have to change. We have to do something differently. And then on top of that, next slide, please, was the question of who will lead the change, right? So we want change, we want to see change, we're willing to even change ourselves, but who's willing to lead it? And that's when everybody disappears, right? No one wants to be a part of that. And next slide. And beyond that is like, this is where we find ourselves, the framework. This is how we came up with it. We'll take the lead, we'll take the hit and start having the conversations about what this looks like, and then create just a skeleton, just to begin the conversation about what it would take for the state to get to zero. Next slide, please. So let's talk about the state, the current state of things. A lot of you all are familiar with the Illinois HIV Care Continuum, so I'm not going to go through it one by one, but, and it's true, the state is, we're making great strides. I think we had less than 1,000 cases, recently, which is the lowest we've ever gotten. However, we still see health disparities. We still only have less than 44% living virally suppressed, and half of those who are living with HIV are minorities. They're Black. In the state, 47%. In Chicago is 50%. Next slide, please. So in addition to that, why now is, again, we have precedents. We've seen it work in other areas. We've seen it work in Washington State and New York, where people come together and really come together and pull together a plan that can be implemented and make dramatic impact in this epidemic and make a dramatic impact. We have the Affordable Care Act, which has been really amazing at making sure that people are getting access to their medication and to treatment. We have involved government parties. Again, we have IDPH and CDPH at the table who's having conversations with us. We have the new research. If you're not familiar with U equals U, it's the new research that's come out that is clearly defined that undetectable equals untransmittable when it comes to sexually. HIV cannot be transmitted sexually if you have been living undetectable for over 6 months. This is great news. We have new technologies such as PrEP and injectable PrEP and the direction that that's going. We have a lot of tools in our arsenal right now in order to really make a change in this epidemic. So we felt that, yeah, we can do this. Next slide. So this is where we came to our aims. We looked at the tools we had, and we also looked at what research was out there, and this is how we came up with our aims. So when it came to changing, our change was going to be that we were going to make sure to get ARV medications to everyone who needs them. This is for treatment or for prevention. So we intend to, number one, suppress viral load in the populations of persons living with HIV, and number two, make sure that the utilization of PrEP goes up, and other things that are coming out, medical tech that's coming out, making sure that the uptake is there and among vulnerable populations, making sure that we're seeing that increase in utilization. Okay. And we also believe that along with that, with those two aims, that they're common. It's a common pathway. No, it's okay. You can go ahead to the next slide. It's a common pathway for both of those, for PrEP and for ARVs. It's very similar. They're both going to take outreach, education, and marketing, which we're familiar with, HIV testing. It's going to take linkage to care. It's going to take the same retention and engagement in care, the continuum. It's still going to mean prescription use, but we want to make sure that we're making sure that that's most important, PrEP and ARV prescription use. And then also the support services, which we're familiar with, but making sure that they're continuing to support the retention and engagement in care to make sure that those who need it are getting access to PrEP and ARVs. And all those support services, all of these services, from outreach and education and marketing to the support services, all must be culturally responsive. Okay, we need to be conscious and working towards health equity because, again, as the earlier slides show, we still, even though with the progress we've made in the state, we still have disparities being shown. We still have those who are suffering more than others when it comes to this epidemic. Next slide, please. So with those two aims, PrEP and ARV utilization, we found that if we could just increase PrEP and ARVs each by 20%, it could mean fewer than 100 new HIV cases per year by 2027. So what this means is, right now the utilization of PrEP in Illinois is at 10%. If we could increase it to 30%, and if we can increase ARV usage from roughly 50%, I think we were at like 44 in the state, but roughly 50% to 70%, we could reach functional zero, which means fewer than 100 new HIV cases by 2027. Next slide, please. I just want to further explain this. So here, this is some information that we received, some modeling that we received through University of Chicago, which has a couple different scenarios. So you can see ART use is the green line. So antiretroviral, if we increase that usage from 50% to 70%, we would be at roughly, and it's on the other side of your slide, 430 new cases of HIV. Now, if we increase PrEP usage from 10% to 30%, we'd be at around 200 or so. But if we do both, if we can move the needle for both of those, we would be under 110 new infections by 2025. So I have a poll. I think if you could pull it up. I'm going to ask if you all would be willing to answer a couple questions because, again, we want some feedback from you. So first I wanted to ask, do you believe that HIV treatment is a valuable tool? And you have two choices, yes or no. And Josh, you can just let me know when they're wrapped up and we can go to the next one. The next poll question, please. And then I also like to know for those on the call, and I appreciate you all giving us feedback, do you think PrEP is a useful intervention, a useful prevention device? And then we can go back to the slides when we're all wrapped up with that. And thank you for answering those questions. I'm going to have a few questions intermented, and then we'll also have time at the end for your individual questions as well. Okay, so again, 2020, increase PrEP usage by 20, increase, yeah, that's fine. I'm getting the PrEP slide again. Okay, so increase, so right now what we have our status quo, no change. Right now it's costing, it's projected to cost the state roughly $5.2 billion. Okay, that's looking at, you know, if we have about, up through the next 10 years, roughly 15,000 people living with HIV, new cases of people living with HIV or who are not on treatment, it would cost the state $5.2 billion. That's the status quo. If we increase PrEP and ARV usage by 20%, we could get to zero by 2026. Okay, so maybe right now getting to zero isn't our status quo, but it can be. It could be our status quo if we make those simple changes. So I have a question for you all, another poll question. And actually there are a couple because I want to know with the information that you have, and please, if you have questions, because I don't want to go through this too quickly, if you have questions and you would like me to explain more about it, please just go ahead and type it in there and I'll take some of your questions even now before the poll. But do you believe with the information that you just received about 2020 and the modeling of projecting what could happen in the next 20 years for the state of Illinois, do you believe that we can get to 2020 percentage increase in PrEP and ARV usage? And actually, we're not even talking about by 2026. It's just, do you believe we can do an uptake in 20% of PrEP use and an uptake of 20% in antiretrovirals? Let me know, yes or no. And then when we're done with that, I have a follow-up question. Oh, these are the results. Thank you. Okay, 88% said yes, that's great, and 12% said no. I appreciate your feedback. Thank you. I have another question now, a follow-up question for you. Do you think that we can reach, do you think that your peers and colleagues would believe it? Do you think that your peers and colleagues will believe that we can get to 20% increase in PrEP and 20% increase in ARV use?
Jolie, I'm sorry, I was on mute. I double-clicked that, and I can't get back to that poll question. It's already closed.
It's okay. No worries. No worries. Well, how
Do you want to
about,
go ahead and go to the next question?
yes, that's fine. No worries. Thank you, Josh. I appreciate that. Okay. So this is my next question to you all, and thank you all for hanging in and giving us feedback on this framework. Do you believe that we can get to a 20% increase in PrEP and ARV use by 2026? We're projecting this out over 20 years. I'm sorry, over 10 years. Whoa, too many 20s. Over 10 years. And yeah, we'd like to know, do you believe that we can do that and see and get to functional zero by 2026?
All right, Jolie, I'm going to go ahead and close that poll.
That's great.
Share,
thank you.
Share the results.
Okay, thank you. So, okay, so 80% of you all believe we can do it by 2026. Great. And 20% still not believing that. Thank you. Thank you for sharing. And again, if you have comments that you'd like to throw out now, feel free to do that. I have another follow-up question. This is the last one, so you won't have to do polls all day. But to the previous question of, do you believe that we can reach the 2020 increase by 2026? I'm asking, do you think that your peers and colleagues will believe it? If you go back to your office, you go back, visit with someone over lunch, and you mention, this is this Illinois Getting to Zero framework, and they're, saying that data shows that we can get to by 2026 we can see functional zero. Do you think that they'll say, wow, that's great, I believe that, I could see that happening? Or that would be great, but I don't think it's possible, or I don't know if that's the way. So if you could give me your feedback, give us your feedback, we'd appreciate it.
All right, Jolie, I'm going to go ahead and close that poll and share the results.
Right. Okay, thank you. So 59% of you do think your colleagues would believe it, but 41% said no. Okay, this is some really great feedback. I appreciate it. So this is where we are right now, but we can go to the next slide, that's fine. 2020 has been the framework that we've been working on, looking at data to see what would need to be done. But now we're talking about what's next. What would crafting a Getting to Zero plan look like? And this goes into who wants to lead the change. And I joked and put in there that you can insert your name here, because that's what we need, is for people who are willing to lead this change from this point on. Those who are involved now are looking for the state and the city to appoint the state and the city to appoint a year-long task force that would work to actually create an Illinois Getting to Zero blueprint. So right now we've talked about a framework, again, a skeleton, but what we need is a filled out plan. How do we increase the uptake, especially among vulnerable populations for PrEP, and how do we increase the utilization of treatment, ARVs and other treatment for those who are living with HIV? So that needs to be filled out, and we're hoping that the governor and the mayor's office would work, not necessarily work together, but would both support a year-long task force to create that plan, and that task force would oversee the implementation of a blueprint over a 5-year period. Next slide, please. And so right now, that's our hope. So right now we're looking at, again, this is the framework, this is the data that we have. We want to share that with the community and get reactions to it. We're working to take that, the information that we've gotten, because we've been doing this for the last few months sharing this information, and we're taking that information and synthesizing it so that we can actually give it back to the community. So be looking for all of this information, some of the information that you gave today, and share it with us, thank you again, to be coming back in various ways so that you'll know what responses that we received overall to the framework piece and to the plan moving forward. And speaking of the plan moving forward, I wanted to share with you the extension of our timeline. So we came together, and we've been talking for the last year or so, but we came together in January and worked towards just putting together the framework. And at this point, we're looking to extend for another year, beginning with July, another plan for a year that would look to formalize the Getting to Zero plan, like the actual blueprint plan, not just the framework that we've worked on. So AFC in August is going to facilitate a Getting to Zero like kickoff summit. They're going to also put someone in place who will be working specifically designated to work on the Getting to Zero initiative. In October, they'll have another meeting to begin preparing on the plan. From November through April, November of this year through April of 2018, they're going to be creating subcommittees and work groups who will be meeting periodically, creating or doing focus groups to make sure that they're getting information back from community. By April of next year, AFC is going to work on creating a communication strategy, making sure that there's a website and social media presence. And then by May, the plan is to have a first draft of the Getting to Zero plan, of the Getting to Zero blueprint. And a month after that, by June, having that plan ready for approval and implementation. Now, this is an ambitious plan, but our last 6 months have been ambitious, and we've been able to do it because we've had people who've really been invested. So if this is something that you think that you're interested in and you're invested in being a part of, and committed to seeing this happen too, I would encourage you to follow up. There's some information on the next slide, I think. Oh, there's questions. So yes, I'm sorry. My information is on this one. And so thank you. If you want to email me, or you can also email John Peller, jpeller@chicago.org. And then we also will have time for questions, but I just wanted to let those know who are interested. If you want to contact me or John via email to follow up, you can do that to let us know that you're interested in becoming a part of the next year plan. But if you have questions now, Max is going to walk us through so we can actually have some conversation and questions.
Thank you, Jolie. Excellent, excellent job on the presentation today. If you have questions, continue to put those into the question feature. We have a couple questions coming up right now that I definitely want to address in comments that people have. One of the things that, just going back to the very first part of your presentation, was having been a lab science student in the 80s before HIV has been identified, and seeing where we are today. It is very exciting to see the latest in ART and PrEP. So that was addressing, the 80s, 90s, and what does HIV look like now. So a couple of questions also were addressed, was like, could you explain a little bit why there was an importance to do a statewide campaign versus just a City of Chicago campaign or Cook County campaign? I know other places across the country have focused within their cities, the Bay, San Francisco, and then also New York, but others have done like statewide, Washington and Arizona. Why was it important for Illinois to do a statewide campaign?
I think because those who, again, were at the table early on were thinking about the state entirely. I'll also add that when we looked at what was happening between the state and Chicago and the county, I mean, there's some differences, but they're not vast differences. We're as a total state doing, we're at 44 to 50% virally suppressed. It's not like the state is doing so much better and the city isn't, or the city is doing so much better and the state isn't. The same thing needs to change. Now, the how will be different from, across the state, right? But this was just about a framework of what would need to change, and those percentages need to change across the state and city.
Great. Thank you so very much, Jolie. Next question. There's kind of when some of the other states that were addressed are more liberal-minded states, such as when we talk about California and New York, and do not have split governments, such as that we have a Republican governor in the state of Illinois. What were there any thoughts about like how that plays a role within us getting to zero in this state? And can we talk a little bit about like how IDPH has been at the table around this?
Sure. This is something that I think we've talked about, but again, just um, didn't want to find ourselves limited by, which is, yes, we do have, Governor Ronner is seated now, and yes, he is a Republican governor, but when it came to Preppy, then once he, someone sat down and talked with him and he understood it, he was open to PrEP. And not that we're banking on that with Illinois getting to zero, but it was, we did not feel that him being seated should be a deterrent, and nor did we believe that it would definitely be a deterrent. And again, having IDPH at the table and knowing that Director Shaw has been very supportive of this plan, and even the city has, the mayor's office has been supportive of a Getting to Zero initiative. So knowing those things seemed to go beyond just who was currently seated as our governor, because again, this is a plan that is looking at, first of all, the plan is coming together maybe in, I mean, not maybe, but it's coming together in another year. And then now we're talking about a 5-year plan of implementation. That's likely going to go beyond Governor Ronner. Does that answer your question? Please let me know if it doesn't.
Yes, it does. Thank you so very much, Jolie, for that. Next question. What do you think are some of the barriers of people getting connected to care or connected to PrEP right now that we actually want to change in the next couple of years to create, to get closer to this Getting to Zero platform?
So that's a tricky one because, of course, I have my own thoughts about that, but when it comes to the Illinois Getting to Zero framework, it's a framework. We did not touch the how. We just looked at what would need to be done, not the how it would be done. So, and I've joked in other presentations, so I really know that I need to lose maybe a little weight, 10, 15 pounds, if I want to wear these jeans that I keep holding on to. Like, that needs to be done. I have not quite figured out the how it will be done, assessing everything about what I need to eat, when I'd work out, I haven't figured out the how, and that's what this framework is like. It's like we acknowledged and looked at the research that came out and the modeling that came out and said, okay, this is what would need to be done for us to actually see a dramatic impact in this epidemic in the state. But we really strayed from the how because we truly believe that there needs to be, the task force needs to be representative of everyone who's being affected by this epidemic and their input on how it's done. So yes, I mean, I have my own personal views on it, but I think this portion of discussion is really just about the framework.
Thank you so very much, Jolie. 2 comments that were. One person said, "Look at Arizona's plan and how conservative that state is." That is a very good point to bring up. Arizona has 2 Republican senators, Republican governor, Republican-controlled state in their House and Senate stateside, and still came out with the Getting to Zero plan. So that's any state can definitely do this. And then the next piece is someone had said that they had answered no to getting to 2020. The main reason is that they felt like they needed to get to the right population. And so I guess the real, when folks are talking about getting to the right population within this framework, what are ways that we're thinking in order to get to the people that need it the most?
I think that's a great comment and assessment, because even when we did the modeling, the BARS modeling, I think a fair question that the task force will have to ask itself. Well, what's the uptake percentage needed in young Black MSM for this to happen? Like, what's the uptake percentage needed for that specific population in order for them to be affected and see an actual dramatic, impact in that group when it comes to getting to zero? And I think the task force, so even though we've looked at some of the how, the task force is really going to looked at some of the what, or the what needs to be done. The task force will really be looking at the how and looking at the demographic piece. All of this, again, not just the path to ARV and PrEP use is culturally inclusive or culturally sensitive. This how we get there overall is going to have to really look at health disparities. So again, and I bring that back because the people who come to the table for this task force are really going to have, it's a task. They really have their work cut out for us, or we have our work cut out for us in moving forward into the how piece. So I think that was a great thing to bring up is, how do we make sure, how do we take responsibility as those, all of us who are on this call, to make sure that this does work and it works for all the populations, especially the vulnerable populations across the state.
Thank you so very much, Jolie. Next question, and thank you for that answer and really going into deep in how we think about that. Next question is, what is the role of the Illinois HIV Planning Group in the Getting to Zero framework, as well as CAHEES, in how this framework is now and how it will come to be?
That's a great question. I think we've had members who were a part of the early initiative who are on the Illinois HPG and in CAHEES, but they weren't the leading, those groups weren't the leading groups. There actually, this has been a come together of a lot of different agencies and stakeholders. So are they involved? Yes. The CAHEES was presented to in May. The Illinois HPG were presenting to in August. Although members from the Illinois HPG are a part of this and have been presented to at other times. So, but they're not, and I don't know exactly how they'll be involved in the task force. Again, maybe that'll be outlined in the future, but as far as this point, it's been as other community advocates, which we've just kind of, we've shared information to get input from them, but they haven't been the driving force behind the framework.
Thank you, Jolie, for that as well. Next question is, how are we working to get, I know in the city's plan currently to reframe how we're dealing with HIV in the city, housing has been a really important piece, along with dealing with the other social determinants of health in the ways in which we get, start to end HIV in the city. Are there other programs such as housing and other things that are social determinants of health that we want to add into this task force, and when we're talking about how we end or how we get to zero in the state?
Mm-hmm. Well, I think one of the novel things about the framework conversation was that there has to be a need for organizations that are working with, who haven't in the past worked hand in hand in HIV prevention, but are a part of it. When we talk about Medicaid, Medicare, and other government entities that really need to be at the table. So I think that's one of the novel ideas about this, which is that making sure that the task force is backed by the state and the city and will have access to and have support from other groups that, if with that support, could really make a difference. So when you talk about housing of course is important because it's one of those fundamental things that people need in order to, it's Maslow's hierarchy. It's at the base. So making sure that the relationships with those who are in housing is there beyond just HIV housing specific, you know what I mean? To make sure that there's access and that there's help and support. So that's one of the things that I think is great about this conversation from the start, is that it wants to make sure that for sustainability and success, that this conversation goes bigger and wider than it has ever gone before.
Thank you again for that one. Next question, and kind of in the same realm on this, is what are the ways that the task force wants to get greater geographical representation from the state, kind of from all the areas throughout the state? Is that a priority also for the task force?
Mm-hmm. It is a priority, and that's one of the things that the feedback has been really helpful, the feedback and the connections that people have brought to say, are you making sure you're reaching the southernmost part of the state, the east, so we've been very intentional. And I think the task force, we've been very intentional to this point for the framework, but the task force, I think, already has it from the feedback that we've gotten from the framework, that the blueprint will have to dig even deeper and make sure that it's really getting information from all points. So I think we've been intentional in the framework, but I think I suspect that it'll be even more so with the task force.
Thank you so very much. If there are no other, please submit. If you have any other questions, please submit them now. We have one more question left. If there are no other questions, that's also fine. We will just end a little early. Next up, Jolie, we're talking about, many times we talk about barriers to care, things that will, not get folks connected to care. I know we've already talked about housing, but the other thing is access to employment for specifically people living with HIV, and then also the communities most impacted. Are there ways in which we'll also be talking with folks in the either labor department or folks who generally hire people living with HIV in communities most impacted, also at the table in working to help get to zero?
No, I definitely would hope so. I think we've had the conversation again. Here's my thought on that, and I'm actually thinking of U of C. They received one of the ATN grants to do a project called Work to Prevent, and it's looking at how creating jobs and really increasing like socioeconomics for vulnerable populations, how that can actually be a prevention tool. And I'm thinking of it because I think of even like U equals U, how that changes the game for a lot of programming and for funding and for things like that. And I think as we get research like Work to Prevent, that's, we get that research back and it's out there, because we talk about it and we kind of know it, but sometimes you need people to have that in black and white. CDC, sometimes they need that in black and white, to see. And so I think the more, research and backing that we have, the more buy-in that we'll get from labor groups to make sure that we're all working together. Again, though, this plan right now, the framework really stresses that there has to be connection and buy-in from a lot of different areas: housing, labor groups, insurance, like all of these things need to come together in a way that they haven't come together before in order for us to really reach our goal of functional zero, which I think we can do. I think we can do it.
Thank you, Jolie, for that. One last question. What does U equals U mean?
U equals U means undetectable equals untransmittable. It's research that shows that those who are living with HIV, who are in treatment and virally suppressed, they're undetectable, cannot sexually transmit the disease. So undetectable equals untransmittable.
Thank you so very much, Jolie. That will conclude our question and answer piece. Again, please keep in touch. You can email Jolie at jolieholliman@msn.com. Holliman at msn.com. Thank you all for being part of this webinar, and looking forward to everyone working hard for us to get to zero in the state of Illinois. Thank you all so very much.
Thank you.